Good evening friends, you are most welcome to Think Ice channel. Today we are going to discuss Practicing Anthropology, which is written by MAAN, IGNOU, and our topic is Physiological Anthropology. Let us begin the topic. First, introduction part, then human cardiovascular physiology and health status, in which blood pressure, heart rate and pulse rate we will discuss, and after that cardiorespiratory fitness, physical fitness and physical performance test, in which methods to access physical fitness we will discuss. After that, environment and human cardiorespiratory function traits and impact of air pollution on cardiorespiratory function, in which impact of smoking on cardiorespiratory function we will discuss, impact of occupation on cardiorespiratory function we will discuss. At the last, we will discuss the summary. Learning objectives are: after going through this unit, you will be able to know about the relation of human physiological traits to their health status, the cardiorespiratory fitness to physiological traits, and the consequences of environmental factors on human physiology. Introduction part. In the past decade, the growing epidemic of health risk has led to health promotion strategies focused solely on behavioral changes and towards ecological approaches that engage communities in fostering environment and behavioral changes. This general trend coincides with the increased popularity of interdisciplinary and participatory approaches to health promotion, creating new opportunities for anthropologists to play a role in community health promotion. The health promotive capacity of an environment is understood not simply in terms of the health effects of separate environmental features, example, air quality, seismic safety, or social climate, but more broadly as the cumulative impact of multiple environmental conditions or occupants' physical, emotional, and social well-being over a specific time interval. Stockholm's 1996. Anthropologists bring an important understanding of the interaction of physical and social environmental conditions and can be strong participants in such an inherently interdisciplinary approach. In this unit, we will review the interaction of human physiological fitness and environment with respect to their health and morbidity. Second headline is Human Cardiovascular Physiology and Health Status. The cardiovascular system consists of an interconnected continuous vascular circuit containing a pump, that is heart, a high pressure distribution system, that are arteries, exchange vessels, that are capillaries, and a low pressure collection and return system, that are veins. Functionally, the heart consists of two separate pumps. The left heart receives blood from the body and pumps it to the lungs for aeration, pulmonary circulation, and the right heart accepts oxygenated blood from the lungs and pumps it throughout the body, systemic circulation. In the other words, the heart provides the force to propel blood throughout the vascular circuit. Let us discuss the blood pressure. With each contraction of the left ventricle, a surge of blood enters the aorta, distending the vessel and creating pressure within it. The force exerted by blood against the arterial walls during the cardiac cycle is known as blood pressure and reflect combined effect of arterial blood flow per minute, that is cardiac output, and resistance to that flow in the peripheral vasculature expressed as blood pressure is equal to cardiac output into total peripheral resistance. The highest pressure generated during left ventricle contraction, termed systole, reflects the systolic blood pressure, while during ventricular relaxation, termed diastole, the aortic valve closes and the natural elastic arterial recoil maintains a continuous pressure, providing a steady blood flow into the periphery. The arterial pressure continually declines as blood flows. The lowest pressure reached during ventricular relaxation represents diastolic blood pressure. In a normal individual, systolic blood pressure varies between 110 and 130 mmHg and diastolic blood pressure between 60 and 80 mmHg, millimeter mercury level, mmHg means. However, arteries hardened by mineral and fatty deposits within their walls or arteries with excessive peripheral resistance to blood flow from kidney malfunction induce systolic blood pressure as high as 300 mmHg and diastolic pressure above 120 mmHg. Although there is a continuum of cardiovascular risk across level of blood pressure, the classification of adults according to blood pressure provides a framework for differentiating levels of risk associated with various blood pressure categories and for defining treatment threshold and therapeutic goals. Vasan et al. 2001. According to the classification approaches developed by the Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure (JNC 6), the adults may be categorized as per the given table number 2.1. What is that? Classification of blood pressure for adults. SBP means systolic blood pressure, DBP means diastolic blood pressure. Blood pressure classification. In the case of normal blood pressure, which is less than 120 SBP, systolic blood pressure mmHg, and less than 80 DBP, diastolic blood pressure mmHg. In the case of pre-hypertension, blood pressure systolic is between 120 to 139 mmHg and diastolic is between 80 to 89 mmHg. At the stage 1 hypertension, SBP will be between 140 to 159 mmHg and diastolic between 90 to 99 mmHg. At the stage 2 hypertension, systolic blood pressure will be greater than 160 mmHg and diastolic blood pressure will be greater than 100 mmHg. In children and adolescents, hypertension is defined as BP, blood pressure, that is on repeated measurements at the 95 percentile or greater adjusted for age, height and gender. Decades of epidemiologic research has established elevated blood pressure as a major contributor of cardiovascular diseases. O'Donnell et al. 2002. Elevations in both systolic and diastolic blood pressure are associated with strong continuous increases in risk of stroke, coronary heart disease, congestive heart failure, peripheral vascular disease, and renal disease across a very broad range of blood pressure levels. Caroline E. Barlow et al. 2004. Framingham Heart Study has indicated the blood pressure values between 130 to 139 at the systolic blood pressure and 85 to 89 at the diastolic blood pressure mmHg are associated with a more than two-fold increase in relative risk from cardiovascular disease CVD as compared with those with BP levels below 120 to 80 mmHg. JNC 2003. Worldwide 7.6 million premature deaths, about 13.5% of the global total, and 92 million disability adjusted life years. Delhi, DALYs, 6% of the global total, were attributed to high blood pressure. Furthermore, it has become a common health problem globally as a consequence of increased longevity and prevalence of contributing factors such as obesity, physical inactivity, and an unhealthy diet. WHO 1983. High blood pressure imposes A chronic strain on normal cardiovascular function, if left untreated, severe hypertension leads to congestive heart failure as the heart muscle weakens and is unable to maintain its normal pumping ability. Degenerating brittle vessel can obstruct blood flow or can burst, cutting off vital blood flow to brain tissue and precipitate a stroke. Thereby, hypertension plays a major etiologic role in the development of cerebrovascular disease, ischemic heart disease, cardiac and renal failure. This burden is distributed over different economic regions, age groups, and blood pressure levels, and is certainly not limited to people with hypertension. Vasan et al. 2001. In addition, hypertension often coexists with other cardiovascular risk factors such as tobacco use, diabetes, hyperlipidemia, and obesity, which compound the cardiovascular risk attributable to hypertension. Worldwide, these coexistent risk factors are inadequately addressed in patients with hypertension, resulting in high morbidity and mortality. WHO 1983. Absolute risk of cardiovascular disease. For any given level of blood pressure rises with age, the systolic blood pressure continues to rise throughout life in contrast to diastolic blood pressure, which rises until approximately age 50 and tends to level off over the next decade and may remain the same or fall later in life. Thus, diastolic blood pressure is more potent cardiovascular risk factor than systolic blood pressure until age 50. Thereafter, systolic blood pressure is more important. JNC 7 2003. An elevated systolic blood pressure provides a more reliable and accurate predictor of the risk associated with hypertension than diastolic blood pressure. Catch 2007. In the context of this large and growing disease burden, strategies to improve population health require consistent and comprehensive measures of the contribution of major risk factors to premature mortality and disability. 6 or 7, these estimates can elucidate the potential for prevention and provide an important input into health planning and other cost utility decisions. Therefore, the importance of modifiable cardiovascular health risks such as blood pressure should not be overestimated or underestimated. Vasan et al. 2001. Effective prevention strategies include lifestyle changes, regular physical activity, modest weight loss, stress management, smoking cessation, reduce sodium and alcohol consumption, and adequate potassium, calcium, and magnesium intake. Lifestyle modification to prevent and manage hypertension. Modification recommendation: approximate systolic blood pressure reduction. Weight reduction. First case: maintain normal body weight, body mass index 18.5 to 24.9 kg per meter square. Approximate systolic blood pressure 5 to 20 mmHg per 10 kg. Adopt DASH eating plan, DASH dash eating plan. Recommendation are: consume a diet rich in fruits, vegetables, and low-fat dairy products with a reduced content of saturated and total fat, toned milk that is. And approximate SBP reduction 8 to 14 mmHg. Third case: dietary sodium reduction. Recommendation: reduce dietary sodium intake to no more than 100 millimole per day, 2.4 gram sodium or 6 gram sodium chloride NaCl, and approximate SBP reduction 2 to 8 mmHg. Physical activity: engage in regular aerobic physical activity such as brisk walking at least 30 minutes per day, most days of the week. and approximate SBP reduction 4 to 9 mmHg. In case of moderation of alcohol consumption, recommendation limit consumption to no more than 2 drinks, example 24 OZ beer, 10 OZ wine or 3 OZ 80 proof whiskey per day in most men, and to no more than 1 drink per day in women and lighter weight person. An approximate SBP reduction 2 to 4 mmHg. DSH means dietary approaches to stop hypertension. SBP means systolic blood pressure. From the 7th report of the Joint National Committee on Prevention, Detection, Evaluation and Treatment of the High Blood Pressure. High levels of leisure time physical activity have been associated with a reduced risk of hypertension. Exercise promotes weight reduction, decrease bad cholesterol level in the blood, the low density lipoprotein LDL, as well as total cholesterol, and can raise the good cholesterol, the high density lipoprotein level HDL. When combined with other lifestyle modifications such as proper nutrition, smoking cessation, and medication use, it can dramatically reduce the risk. However, genetic factors contribute significantly to the inter-individual differences in endurance training induced changes in blood pressure. Regular exercise controls the tendency for blood pressure to increase over time and relates rhythmic muscular activity. Regular exercise controls the tendency for blood pressure to increase over time and relates more to prevent early mortality than to extending overall lifespan. During rhythmic muscular activity, vasodilatation in the active muscles reduces total peripheral resistance to enhance blood flow through large portion of the peripheral vasculature. Increased blood flow rapidly increases systolic blood pressure during first few minutes of exercise, and then level off at 140 to 160 mmHg for healthy individual. As exercise continues, systolic blood pressure declines as the arterioles in the active muscle dilate, further reducing peripheral resistance to blood flow. Diastolic blood pressure remains unchanged throughout exercise. During maximum exercise, systolic blood pressure may increase to 200 mmHg or higher among healthy individuals despite reduced total peripheral resistance. This level of blood pressure most likely reflects large cardiac output during maximal exercise by individuals with high aerobic capacity. Upon completion of exercise, blood pressure temporarily falls below pre-exercise levels, which may last up to 12 hours. Such post-exercise hypotension could be explained by the significant quantity of blood in visceral organs or skeletal muscle during recovery. Consequently, venous pooling reduces central blood volume and decreases arterial filling pressure and hence arterial blood pressure. Systolic and diastolic blood pressure decreases by 6 to 10 mmHg with aerobic exercise training in previously sedentary individuals. Relatively prolonged reductions in post-exercise blood pressure justify recommending multiple periods of physical activity interspersed throughout the day. McArdle et al. 2007. Thank you very much.